Okay, good evening, everyone. Good evening to all our attendees. Let's start the 9th TUGSS Asia Symposium, having a lecture series on a very interesting topic about benign biliary strictures. We have three specialists, three speakers for tonight to talk about from the diagnostics, imaging, to the endoscopic and surgical management of benign biliary strictures. So let's start. Before we start the lecture series, let's hear some words from our TUGSS coordinator from the Philippines, Dr. Vermi Garcia. Dr. Garcia.
Good evening, everyone. Thank you for coming and attending our TUGSS Asia Symposium. Today, we have prepared for you lectures and some case discussion regarding benign biliary strictures. So before we start, I would like to thank, of course, our speakers who have shared their time for us tonight, Dr. Disha Kapoor, Dr. Arlene Canones, and Dr. Raymond Joseph Romero. Also, we would like to acknowledge our panels who will be officiating our symposium tonight. As you have seen right now, Dr. Armin Mendoza, Dr. Jason Rafael Nadumba later during the case discussion, and Dr. Jimmy Chuminsu from Taiwan. So later we'll have a series of lectures from diagnostics up to the surgical and endoscopic managements of benign biliary strictures. And after such, we will have a few cases that will be presented that will tickle your mind and your knowledge about this disease. So I hope there will be a very interactive session later on with your question and answer and the feedbacks and comments from our lecturers and panelists. Again, thank you for joining us tonight. And I give you back the floor to Dr. Armin Mendoza to proceed with our symposium.
Thank you, Dr. Garcia. So we begin with our first lecture for tonight, and let me introduce our speaker. So our speaker for our first speaker, he is a consultant of HPB surgery in Batangas Medical Center, Mary Mediatrics Medical Center, and University of Perpetual Health in Laguna, Philippines. He is currently the chief of the section of minimally invasive surgery at Mary Mediatrics Medical Center, and currently the chairman of the Department of Surgery at Metro San Jose Medical Center and Medical Specialist 2 in the section of HPB at Batangas Medical Center to talk about diagnostics and preoperative considerations in benign biliary strictures. Our speaker for tonight is Dr. Raymond Joseph Romero. Dr. Romero, please.
Hello.
Yes, Dr. Romero.
Sorry, my internet is very unstable right now. Can you hear me now?
Yes, doctor. Loud and clear naman. Go ahead. You can share your screen already.
Yeah, let me share my screen.
Thank you.
Okay, can you see my screen?
Yes. Yes, doc.
Yeah, okay. Good day, everyone. So it's a stormy night here in our place. It's in Batangas. So I hope everyone is okay. Again, I'm Dr. Raymond Romero. I'm a consultant in HPV at Batangas Medical Center. Today, I'll be discussing some few points to consider in the management of benign biliary strictures and its diagnostics. So I have nothing to disclose. And again, thank you for inviting me as a speaker also. So let me start by showing you a lab video. This is not mine, but I hope we can learn something from this. As you can see here, the surgeon is trying to isolate and clip what he knew of cystic duct. So again, there's another tubular structure behind it. As you can see, he's trying to clip it and cut it also because he knew that this is a cystic artery. Then upon dissecting, something bled and he tried to control it by clipping. Then he tries to remove the gallbladder and further, he noticed a bile leak. Okay, so at this point, I want you to pretend for a minute that you are the surgeon here and you realize something is wrong and that you may have injured the common hepatic duct. So you decided to do a cholangiogram. The cholangiogram shows a distal flow of contrast into the duodenum, but the proximal ducts cannot be seen. So what do you do next? Do you proceed to a laparoscopic hepatic jejunostomy or convert to open and perform your bypass, or just call for help? I know some of you here will convert it to open and at this point do your repair. I believe other surgeons here have the technical skills to do it laparoscopically. And personally, I think there's nothing wrong with that. But my point today is that the ability of the surgeon to perform a very good hepaticojejunostomy, whether laparoscopic or open approach, is only a fraction of solution. But what is important of this evaluation is for the surgeon to evaluate the true extent of the injury. So going back to the case, the surgeon here opted to do an open Roux-en-Y hepaticojejunostomy. However, postoperatively, the patient had elevated transaminases in 2000 and was very septic. The GP drain was bilious as well. The patient is not doing good and is very sick. This is the CT scan of the patient. As you can see, there is an ischemia of the entire left lobe. Probably the hepaticojejunostomy has broken down also. So how did this happen? Let's take a closer look again. There are actually two main events that happen here. First is the ligation of the bile duct, and second is the ligation of the artery, which in this case turned out to be the left hepatic artery. The surgeon decided to do a definitive repair without recognizing this very important event, which was ligation of the left hepatic artery. When you ligate one of the arteries, this will generally tolerate by your liver without any clinical consequences. There's usually a flow from the collateral arteries, and the main ones are via the suprahilar arteries, creating a shunt from the right side. The longitudinal shunt via the 3 o'clock and 9 o'clock vessels. However, if you add a biliary injury to this, these shunts may be compromised, so the chances of liver ischemia becomes higher. So if we could go back to that moment of crucial decision making, the surgeon really needs to evaluate himself carefully. Is he capable of diagnosing the true extent of the injury? Not just the bile duct, but the vascular structure that supplies the liver as well. Does he have experience in performing the necessary repair? If not, it would have been best just to call for help. Call someone preferably with a lot of experience in liver surgery and not make the situation worse by doing your reflex bypass at this point. So tonight, let's take a look of a possible consideration in the management of benign biliary strictures. There's no such thing as non-complex for this. There are some things that one should know before taking this case. The primary goal for the treatment of benign biliary strictures is to resolve the biliary duct obstruction, to achieve a long-term ductal patency, to maintain liver function, and without missing a possible malignancy. One must master the liver and biliary anatomy. Be familiar with all the possible causes of benign strictures, both iatrogenic and not. Always consider your patient's performance status as it will greatly affect your decision making. Know all the appropriate diagnostics and the importance of the multidisciplinary approach. So liver is one solid organ, and the only visible marker here is the falciform ligament. The interconnections between the vasculars and the biliary structures serve as the skeletal framework of the liver. The liver, in order to function well, the volume should be adequate accordingly, and all its inflows which are the arteries and the portal vein, and the outflow, which are the hepatic vein and bile ducts, should be intact. So variations in the anatomy is not uncommon, and one should be aware of this in order to avoid injury and able to preserve essential structures. And simply, if you can master anything, you can master anatomy, you can master anything, even if you are faced in this complex biliary injury. Be familiar with all possible disease entity causing strictures and know its behavior. These are the list of benign biliary strictures, and let me run through some of this. So avoid monkeying around of the biliary anatomy because it can cause devastating effect to your patient. Try not to reconstruct if not experienced in doing it because it could aggravate the complexity of the problem. Always rule out concomitant vascular injury and its effect to your liver. Check the patient's performance status, sepsis control, and if can, always call for help. Timing is not a factor. Some will do it early and some would or delay it. In some studies, delaying the surgery can lead to a harmful effect, such as liver fibrosis, sepsis, electrolyte, and nutritional imbalance. But the contention here is do it as early as possible and delay it as needed. Next, the Mersey syndrome is a biliary obstruction caused by the inflammation of the cystic duct, secondary to impacted stone. There are different types of this. Management depends on the severity of type, from the cystic duct stump repair to biliary enteric bypass. This is a case referred to our unit on ERCP. There is a defect at the cystic CBD junction. This is actually a type 4 Mersey syndrome, and eventually he had an hepatic jejunectomy. Next, hepatic TB can spread through hepatic artery or the miliary type, the portal vein, localized type, and the lymphatic spread. Its direct effect to the biliary tree leads to stricture, and management is usually directed to the biliary flow to reestablishment through endoscopic, percutaneous, or surgical with or without liver resection. In this paper, it shows an imaging characteristics of hepatic tuberculosis. It can mimic hypodense lesions and resembles a metastatic lesions on CT. It has a high intensity on T2 weighted images and like a target sign on gadolinium study, as you see here. So in this image, it demonstrates a large lymphatic nodes at its as it causes strictures to the biliary tree. So in dealing with hepatic TB, it is important to reestablish the biliary connection, whether surgical or endoscopic way, in order to save the remaining liver that could still function well and can take the insult of anti-COX medications. Just to share this case of hepatic TB involving the entire left lobe and the periportal lymph nodes. It was referred to us since endoscopic access is not anymore feasible. The initial plan is to do a left hepatectomy and right side bypass, but the severity of the addition, it is impossible to do. So we cannot isolate the periportal area. So with the guidance of ultrasound, we're able to access the left duct and trace the hilar area where we attach the jejunal leaf. So once we saw the right hepatic duct lightens up, so we did the bypass there. And we always put a Hudson's loop for endoscopic access in the future. This patient eventually received her TB meds as the liver function went to normal. Then proper use of diagnostics. The importance of diagnostics on iatrogenic cause of biliary strictures are for mapping defect, where MRCP is most useful, for the biliary study, and CT is best to detect vascular study and lobar atrophy. This is the challenge for diagnosis on non-iatrogenic cause for biliary stricture. This is actually the challenge on dealing with non-iatrogenic cause, because more so on strictures located on distally on hilar areas with no obvious mass on our multi-detector CT or MRI MRCP. The dilemma is we want to avoid unnecessary surgery, but we doesn't want to lose the chance of survival with the surgery for early resectable malignant diseases. So create an institutional algorithm in the approach of this disease to properly allocate the available diagnostics in your institution. Create a team of multi-specialty composed of endoscopic, radiologic, and surgical unit. In this paper, they suggest an algorithm in approaching the biliary structures, biliary strictures. It is obvious a mass detected on RCT or MRI with malignant features will be referred for surgical intervention. However, strictures with no obvious mass, an endoscopic approach with use of ERCP, EUS, and cholangioscope increases the yield of detecting early malignancy. It is preferred to use EUS for distal strictures to get an FNA and cholangioscope for more proximal or hilar strictures. This is an EUS detecting a tumor compressing a distal CVD and referred to our HPV unit for pancreatic duodenectomy. And this is a cholangioscope just showing you a normal looking bile duct. Then this is an image showing a papillary projections. So in this paper, it showed the role of the BB scopes in the diagnosis of these indeterminate biliary strictures. There are cholangioscopic characteristics of neoplastic and malignant disease because sometimes biopsy will not yield informative results and laying the diagnosis on these images. So these are suggestive of malignancy from tumor vessels, papillary projections, nodular or polypoid mass, and infiltrative lesions. We can hear more of this later with our endoscopic surgeon specialist after my lecture. So next, in RMC, Design Medical Center, the collaboration of different specialties yielded more cases and more procedures and better outcomes for each patient. So this is our census from 2016 to 2018. And out of 30 BDI cases referred to RMC, 82% recovered. And those who did not died of intra-abdominal sepsis, hepatic failure, and pneumonia. These 3 patients who did not survive are actually patients who had previous biliary repair from the Fenning Hospital and had other comorbidities. So take home message, the key is to master the anatomy, and you can master anything. The first taper or reconstruction should last longer. Evaluate yourself, and it is not a failure if you ask for help. Beware of strictures that mimics malignant lesions such as hepatic TB, and let the experts manage this complex procedure. MDD is the way to go. So thank you.
Thank you, Dr. Romero, for that excellent lecture. The questions that can be placed in the chat box will be answered later in the panel discussion. So we can continue with the lecture series. Thank you, Dr. Romero.
Thank you.
So for our next lecture, she is an assistant professor at De La Salle University Medical Center. She is a medical officer at Rizal Medical Center as well, and a training officer of surgical endoscopy and MIS in the same institution. She had her fellowship in surgical endoscopy and minimally invasive surgery at Rizal Medical Center and was a research fellow in digestive and endoscopy at Showa University, Tokyo, Japan. She also had her fellowship in endoscopic ultrasound at King Chulalongkorn Memorial Hospital in Thailand. Our lecturer with the topic endoscopic management of benign biliary strictures, Dr. Arlene Cañones. Arlene.
Hello, sir. Good evening, everyone. So if I may just share my screen. Okay. Can you see my slide?
Yes, Dr. Cañones. Go ahead.
Okay. Okay, so good evening again. Thank you for this invite. I am Dr. Arlene Cañones, and I will be discussing the endoscopic approaches to benign biliary strictures. So I have nothing to disclose. So the objectives of this topic is to discuss the role of endoscopy in benign biliary strictures, especially its diagnosis and management, although the diagnosis has already been discussed by the earlier lecturer, Dr. Romero. So in 2017, Professor Hubing and his colleagues published a guideline on the endoscopic management for benign biliary strictures. And it is stated there that the goal of treatment and management for these cases is to resolve the bile duct obstruction, achieve long-term biliary patency, and to maintain good function. So in this table, this shows the list of the possible etiologies for benign biliary strictures. But for this specific lecture, I will focus on the iatrogenic bile duct strictures, as this is what is more common in our practice as surgical endoscopists. So in general, the diagnosis of biliary strictures is very challenging, since most of the time we don't have tumors to be resected. So it is very important to review the history, request for cross-sectional imaging, refer the patient to interventional endoscopists for timely endoscopic procedure, which can also do tissue sampling as well as create a patent biliary drainage. So as part of the initial investigation, cross-sectional imaging tests are very vital, since this is the least invasive amongst the procedures. This can as well guide us to subsequent management of these cases. Endoscopic ultrasound, if available, is as well very helpful, especially for distal CVD strictures, as this can diagnose small tumors that were not seen by the cross-sectional imagings, as was discussed earlier by Dr. Romero. Tissue sampling is also needed, especially for the non-iatrogenic causes of our biliary strictures. Direct tissue acquisition with fluoroscopy guidance through ERCP can be done, or insertion of a baby scope like the spyglass cholangioscopy is very helpful as well, as shown earlier. Okay, so the role of treatment is to obtain long-term bile duct patency, and ERCP is the first line option for patients with accessible papilla. ERCP is safe, it is effective. Of course, it is less invasive and it can be repeated. So depending on the etiology, dilatation using a dilator catheters, or balloon with or without subsequent insertion of biliary stents can be done through ERCP. However, for patients with altered anatomy, like those who underwent Whipple procedure or bariatric procedure, this poses challenge to endoscopists because of limitation of the access. Thus, as backup, we refer patients for percutaneous biliary interventions like the PTBD. As such, other limitations are present, thus we should also know when to refer for surgical management. Okay, so for chronic inflammation, the role of endoscopy is to diagnose and to do surveillance, to maintain ductal patency via stenting or the AUS drainage, or bridge the surgery. So that's the only role we have. And sometimes we refer them directly to our HPB counterparts or to the gastroenterologist for further management. So I will just, this is the numbers of the number we have in Rizal Medical Center for TB, hepatobiliary TB. And as you can see, 25 out of the 46 patients that we had, 25 of those had ERCP stenting. But we need further data and studies regarding this. That's why it's the chronic inflammation is very small numbers. Okay, so let us now focus on the bile duct injuries, as this is the most common indication for endoscopic treatment. So Bile duct injuries are usually caused by transection or occlusion, which can occur during or after the surgery, commonly after cholecystectomy. So these patients are referred to us usually after cholecystectomy, and they would present with jaundice, bile leak, and of course the strictures. In 2015, Kostomania and Boskowski described the causes of bile duct injuries as misidentification of anatomic structures, excessive use of your electrosurgical units, the additions in the gallbladder fossa, inaccurate placement of your sutures and clips, and extensive placement of clips. So since we opened our surgical endoscopy unit 7 years ago, we've had 136 patients referred to our institution, meaning these patients are from outside, had the cholecystectomy from outside, and referred to us for further management, either for endoscopy or for hepatobiliary repair. And if you can see, pre-pandemic, there's a peak of the referrals, but when the pandemic started, we had a decline. But I think our current numbers are now picking up, but we don't have final numbers yet. So this shows that 62% of those patients had the biliary injury during laparoscopy, and 38% are after open surgery. So we grade our injuries using the Strasberg classification. So type A is the most common injury that we have that are treated endoscopically. However, if you can see, we also treat or manage the type D injuries, as well as the type E's, which are the more complicated ones. So 61%, as I said earlier, are managed endoscopically. 14%, however, are done combined, meaning we do the endoscopy first and then refer to our sister unit, which is the HPB unit, for reconstruction. However, 25% of those patients referred to us are or had straightforward reconstruction. So let me share with you the algorithm we follow in our institution and what we teach our fellows and our residents. If we receive a patient with suspected BDI, which are usually identified post-operatively. We will do imaging first to see if there is presence of biloma and map out the biliary as well. For patients suspected with biloma, we usually do abdominal ultrasound first, so we know if we need to drain the fluid through percutaneous drain or diagnostic laparoscopy. If biloma is not suspected or is ruled out, and if patient is stable enough, we immediately request for abdominal CT scan or abdominal MRI with MRCP to map out the biliary tree, thus identifying the type of injury and identifying if there are vascular injuries as well. For type A and D, we direct these patients to endoscopy immediately. Type E patients, especially those with strictures, are referred to us as well for dilatation and stenting. We call in our HPB team in cases of recurrent strictures, complete transection, and complete injuries, especially those with vascular injuries. Immediate drainage and failure to cannulate in ERCP due to complete transection are usually referred to interventional radiology for PTBD. So the goal of endoscopy in bile duct injuries is to control the extrabiliary leak and to the continuation of the bile passage. So we have 3 ways to manage the leak. First is do sphincterotomy. So this is to decompress your biliary tree by slicing through your sphincterotomy or your ampullary opening. If you are familiar with the Strasberg injury, of course, the type A's are usually with retained stones. That's why there's buildup of pressure. So we need to remove the stone. And of course, the stent dilatation. So this is an ERCP with a stent insertion. So of course, we need to access the papilla first, and then assess the gravity of the leak. As you can see at the lateral part, there's a big leak leaking into the JP drain. Sometimes if the bile duct is large enough to accommodate more than one stent, we would try to put in many stents as possible to control leaks, and we only use plastic stents so that we can remove them immediately. So I think this is a French 10 stent, which is equivalent to your to 3.3 millimeters. So if you can see, there was multiple stents inserted. So this is after 3 months, I think. So the stents were removed, and if you can see, the leak is not there already. So there's closure of the leak. So stent insertion is almost always successful. A few days after the procedure, there's noticeable decrease in the drain output. Hence, the JP drain is removed. We usually repeat the ERCP for the removal of the stent after 3 months. However, we always tell the patients about the possibility of stent migration, which generally occurs about 20%. This is significant if the defect has not closed yet. So another mechanism would be the bile duct stricture. These patients come to us jaundiced with history of recent gallbladder surgery. Usually, we also get clues during our initial shots or fluoroscopy, wherein there would be clips located medially, as you can see in this picture. So overcoming strictures secondary to BDI or benign strictures is generally more difficult as compared to malignant strictures, because these strictures have a lot of fibrosis and are really hard to cannulate. This requires a lot of patience from the operator or the endoscopist. One of the most important tool we use is the guide wire. These are needed to be manipulated through the fibrotic stenosis, thus requiring a very good synchronization from the endoscopist and the assist. We usually use the 035 wires, but for more stenotic strictures, we use thinner wires such as the 025 or the 018. In literature, dilatation is described to manage bile duct strictures secondary to injuries. In a paper in 1995, they used pneumatic balloon, which is an air-filled balloon, which they use to dilate the stricture. It is described that there is 47% of recurrence of stenosis if without stenting. So in this video, it showed this is showing the balloon dilatation. So we used a control or radial expansion or CRA balloon to dilate the stricture so that we can accommodate at least one French 7, which is equivalent to 2.3 millimeters, or the French 10, which is equivalent to your 3.3 millimeter diameter. So the goal of the stents are to keep the strictures open and to let the scar remodel around the stent or stents. As I said earlier, we can put more than one stent. Although we commonly use plastic stents, in some cases we need to use metallic stents, especially for bigger leaks and recurrent strictures. But in government hospitals, such as in our institution, there is difficulty in getting the metal stents, because one metal stent costs around 100 to 110 US dollars as compared to your plastic stent, which is about around I think $50. So in a lot of studies abroad, outcomes of plastic stent insertion are better than metallic stents. In our institution, we practice the aggressive multi-stenting strategy, as I said earlier, wherein we progressively increase the number of stents inserted that are exchanged every 3 months for over a year. So that is our limit to put in stents, and then after 1 year, we refer them to surgical management. So progressive multiple stenting aims to let the stricture adapt around the stents so as to avoid exuberant formation of fibrous tissue and instead remodel around the stent. So let me show you a case that we did. This is a patient was referred to us 12 weeks post cholecystectomy. And they did the repair over the tube, but unfortunately, this patient developed a jaundice and was referred in our institution for ERCP. So this is, as you can see, there is difficulty manipulating the guide wire through the proximal duct, but fortunately, the 035 guide wire had the communication to the proximal bile duct. So that is actually a very fortunate occurrence, because it will give us hope that we can cannulate or we can drain the more proximal bile ducts. So to for us to be able to insert stents, we would like to dilate strictures like this, such as what was seen earlier. So this is French 8. So this is the initial stent that was inserted, the French 8. So this is more than 3 millimeters inserted. So after 5 months, patient returned to us for replacement of the stent. But surprisingly, at this time, the stricture can accommodate more than 3 millimeters. So at this point, we were able to insert 2 stents. So 1 French 10 and a French 7. So this is equivalent to 5 to 6 millimeter diameter. So 12 months post insertion of 2 French 10s. So this is what we call the progressive and aggressive multi-stenting. So we are letting the scarring to form around the stent. So this is actually the end point wherein we can pass. So actually, the diameter of the stricture is now as big as 1 centimeter. So this patient, up until now, I think he's doing well. We haven't heard from him, so probably it's he's still doing better, doing okay. So this is not the same patient, but this is just to give you an idea of how much stent we can put. So we can put as many as 5 if the ampullary opening or the bile duct can accommodate. So this 5 stents is equivalent to the one at the right side. So because there is now I think the EUS or the endoscopic ultrasound is gaining popularity. There are now earlier studies on the use of endoscopic ultrasound biliary drainage, such as this one. So we did the hepaticogastrostomy on a E2 injury. So this is a drainage made from the stomach into the left main intrahepatic duct. Okay, so takeaway points. We need to diagnose strictures because it is very important to know if they are benign or malignant. The role of endoscopy is to resolve bile duct obstruction, to achieve long-term patency, and to maintain good liver function. Because endoscopy like ERCP and your endoscopic ultrasound is repeatable, it is safe, and it is less invasive. So that's it. Thank you.
Thank you, Dr. Cañones, for that very comprehensive talk and wonderful videos. Okay, we'll reserve the questions later during our panel discussion. Let's go on to the third speaker. I think Dr. Jimmy Su will introduce our next speaker. Dr. Jimmy.
Yes, and I have the honor to introduce Dr. Diksha Kapoor from India. Dr. Diksha Kapoor have his Bachelor Medicine and the Bachelor of Surgery from the Manuna Azhar Medical College in New Delhi. After that, he has now is the DMB surgery and the DMB surgery gastroenterology in the Medanta Medical Center in Yara, India. She used to have a physician scholarship in the University of Heidelberg from Germany and the HBP and transplant surgery in the Jew hospital located in Paris and France. Now she is the active member of the Medanta Review Board of the Institution Research Review Board. Now we have Dr. Kapoor. You have the floor to.
Are my slides visible?
Yes, clear.
Okay. So again, good evening, everyone. Thank you, Professor Jimmy, for that wonderful introduction. And I will be talking to all of you about the surgical management of benign biliary strictures. So like any scientific paradigm, we need to address what we are dealing with, why we are dealing with it, and when and how to deal with this.
May I have your screen again? I think I lost your screen.
Just a moment.
Can you share screen again? Yes.
Yes.
Yes, I have the screen. Yes.
Oh, super.
Now we have a screen. Yes.
So let's take it off from where we got interrupted. Like any scientific undertaking, we need to know what we are dealing with, why we are dealing with it, when and how do we address the problem of benign biliary strictures. So first of all, the what question. So I believe all of us over here will agree that we are dealing with a benign stricture in an adult age group. A patient for whom there is no clinical or radiological evidence of malignancy. And if it is a stricture which was developed in a non-postoperative setting, then probably tissue sampling would have been performed, which was negative for malignancy. Also to state that the baseline disease trajectory corresponds to a benign disease and does not look like malignancy in any form. And just to make sure that we are discussing with strictures of the extrahepatic biliary system and not the intrahepatic biliary strictures. So why benign biliary strictures develop? So we have a couple of causes for these, and like my previous speakers have done a prolific task of addressing these, I'm just going to summarize by stating that they can be grouped into post-operative, inflammatory, and traumatic strictures. Post-operative, of course, the most common is cholecystectomy. If we take the entire prevalence of benign biliary strictures, about 70% of them would be because of post-cholecystectomy bile duct injury. Strictures following exploration of the bile duct, liver resection and transplant, post-gastrectomy or post-pancreatoduodenectomy. Inflammatory causes, of course, include cholelocholithiasis, chronic pancreatitis. Again, chronic pancreatitis probably being the second most common cause, along with strictures following hepatectomy and liver transplants. And we have recurrent pyogenic cholangitis. A very, very small and a rare group of patients are those who present following blunt or penetrating abdominal trauma, who develop biliary injuries followed by strictures. So I don't think any discussion of a benign biliary stricture can happen without discussing the concept of bile duct injury following a laparoscopic cholecystectomy. Most of us would agree that following an open cholecystectomy, the rate of a bile duct injury is way, way low, about 0.1 to 0.2%. And although this figure of 0.2 to 1.3% is something that was reported way back, and now there is literature that suggests that the rates of post-cholecystectomy bile duct injury have come down, but there is the tenet that how much of it is actually reported. So I think it's a probable number to say that still the rate of post-cholecystectomy bile duct injury is about 3 to 6 times higher in the laparoscopic setting than in the open setting. Laparoscopic approach has become the standard of care for removing a gallbladder for various reasons. It's faster recovery and low morbidity, which has definitely led to an increase in the number of patients who are offered this procedure. And the indications that were traditionally discussed as symptomatic gallstones, etc., have now widened, especially in the Eastern countries like India itself, where gallstones have some kind of association with carcinoma gallbladder, and a lot of surgeons or medical gastroenterologists would possibly believe that even in asymptomatic large stones, a gallbladder should be removed. The accessibility of a laparoscopic cholecystectomy has become so much, and there has been a decreasing threshold to offer this procedure to the patients, and therefore, whatever said and done, how small the rate may be, there is a good number of patients who come to us with bile duct injury, which end up developing a benign biliary stricture. So if you're going to look at the concept of post-cholecystectomy bile duct injury, the presentation may be early or late. Early is likely because of a clipping of the bile duct or a leak. Leak may be from the cystic duct or the main duct. The main duct might have been transacted completely, or it might be a side leak. A late presentation is either an external biliary fistula, so the leak gets converted into a control leak with a drainage which is outside the abdominal cavity, or it can develop into a benign stricture. Stricture also gets contributed by thermal injury, inadvertent use of cautery while dissecting the calloids at the porta, or ischemic devascularization, applications of blind clips, partial sectioning of the bile duct, which ultimately leads to a stricture formation, or a partial clipping, which can happen with extra traction in the cranial direction while holding the Hartmann's of the gallbladder. No discussion can actually be complete without discussing the how of a bile duct injury. So we know the classical concept of a bile duct injury where there is excessive traction at the Hartmann's, which causes the miscalculative interpretation of the common bile duct as the cystic duct. But let's not forget that there are real factors which are contributed by a bad gallbladder itself. The gallbladder may be inflamed. There might be a Mersey syndrome where a large stone on the gallbladder might be impacting on the common hepatic duct and causing or eating away the duct in a part of its circumference. There may be a stone or a stricture in the lower end of the CVD which has been missed in the preoperative setting, and the patient following surgery may present with a collection of bile in the subhepatic region, which could have been either because of a cystic duct blowout. But then exactly classifying and portraying this as a bile duct injury is rather crucial or very, it may not be the correct thing to do in the postoperative setting. Anatomical variations of the biliary anatomy, it's very important. Like Professor Romero already emphasized, the anatomy is the key over here. We need to understand that about 1/3 of the patients who undergo a laparoscopic cholecystectomy are likely to have a biliary anomaly, and one must be very, very cognizant of them while performing the surgery. Drainage or an unclipped duct of Lashka can cause a bile leak in the subhepatic region, which can bring a patient back to the hospital following discharge. The technical or the surgical reasons why a bile duct injury occurs is probably the most important part of this discussion. The visual interpretation of the anatomy may be wrong. So wherever there is a doubt, it is a sensible thing to call a surgeon from another OT or a senior colleague who will judge the vision or the anatomy in an unbiased manner. Excessive cautery should not be used at the pota. Sometimes clip can get misplaced while trying to achieve hemostasis, which can actually result into an injury or a stricture at a later date. And like we have discussed, the undue traction, which is the classical lap cholecystectomy injury. But this is what it is. It's the bullseye concept when it comes to benign biliary strictures, surgical management. The one thing that we need to do is achieve durable biliary enteric continuity. The weightage or the load of wanting to achieve this on a surgeon is actually quite huge, and for multiple reasons. These patients, unlike their malignant counterparts, where the end point of doing a biliary enteric continuity is to either achieve palliation or make them durable for chemotherapy, here patients with benign strictures have a long life expectancies. And if an improper repair is performed, it leads to recurrent complications, recurrent interventions. Of course, the quality of life gets affected. And this is probably the one place where medical legal aspects and the medical legal implications, liabilities are huge for a surgeon. Patients who have strictures beyond a certain time, some studies say it's 3 months, some others about 6 months. What basically happens is that prolonged cholestasis causes a release of TGF-beta-1, which activates the hepatic stellate cells, causes proliferation of the cholangiocytes, and ultimately leads to laying down of excessive extracellular matrix, which leads to fibrosis. So fibrosis in patients who have an obstructed bile duct can be seen after even 3 months, more commonly to happen after 6 months, and if not repaired, can lead to cirrhosis. There might be a fall in the hepatocyte volume, increase in the bile duct cells and the biliary stroma, and this is related to the period of jaundice. And to add to the entire problem, if the patient develops recurrent bouts of infections and cholangitis, it worsens it. Therefore, it's important to realize what will happen to the patient if we don't do a good job at repairing the stricture properly and at the right time. A failure of the repair leads to recurrent cholangitis, secondary biliary cirrhosis, liver failure, portal hypertension, and a huge part of these patients then ultimately go to a liver transplant for a benign disease, which was there to start with. Now let's come to the core of this talk, which is the surgical management of benign biliary strictures. The surgical management is held up by 3 important pillars, and those are the anatomical delineation of the stricture that we are dealing with, how are we going to plan the surgery for the patient, and what are the surgical concepts of performing a good bilioenteric bypass. Anatomical delineation, this is the Bismuth's classification, which is the most commonly used classification for benign biliary stricture, which has been mentioned both by both speakers previous to me. We need to look at the level of the block, and we need to look at the biliary anatomy. There are other classifications, of course, which is the Strasbourg and the Hanover, which have various modifications. But when we are dealing with strictures, this is what the picture looks like. The most common investigation that a patient will undergo for a biliary stricture evaluation is an MRCP. The MR gives us a lot of information. Although some people say that the MR overstages the level of the block, but to my mind, I would rather be over-prepared for a biliary stricture surgery than be under-prepared and encounter surprises during surgery. So to begin with, to look into a cholangiogram, we need to see the right and the left ductal system, the secondary order radicals, and see if any amount of continuity is present or not. So the MRCP gives the best image possible, but in some patients, we might have to perform a percutaneous transhepatic cholangiogram, which is most commonly required for those who have an associated bile leak. So there might be an isolated sectoral duct, which is not dilated and which has not been properly identified on an MRCP, which might need cannulation by the IR team colleagues to either identify the anatomy or to place a catheter before surgery. If this is a patient with an external biliary fistula, a tube cholangiogram can do a good job at delineating the entire anatomy. But again, the importance being that the level of the block should be demonstrated. The right and the left ductal system up to the second order biliary radicals should be identified. And we must look for any biliary anomaly. I think at this point, it makes sense to give credit and the benefit of doubt to the previous surgeon, assuming that there was probably a biliary anomaly which led to a bile duct injury and not just the surgeon's mistakes or visual perception itself. When we are planning surgery, the patient needs to be optimized. A well-prepared patient will lead us to the best results. This is a surgery which should be avoided in a patient who has cholangitis and overt sepsis. I would be showing you surgical pictures from a patient on whom we recently operated, a 37-year-old who had come to us about 3 weeks following a laparoscopic cholecystectomy, laparoscopic converted to open cholecystectomy, who presented to us with a total bilirubin of 39, high-grade swinging fever, and the bile culture and the blood culture grew gram-negative bacilli. So it is important to address cholangitis. If it is not possible to do an endobiliary access to it, it is absolutely justified to put in a percutaneous biliary drainage catheters to take care of the cholangitis and give about 3 to 4 weeks time for the liver to recover from the septic insult. Patients who come after long-standing biliary strictures need to be optimized with respect to their medical existing problems, and they need a correction of the coagulopathy and the dyselectrolytemia. The electrolyte imbalance can also be seen to a very large extent in patients who have a biliary fistula, who are draining about 500, 600 ml of bile. And it's important that this is corrected before taking the patient to OT. I've mentioned this before, and I cannot mention it more emphatically, that patients who have a complex biliary stricture benefit from a percutaneous transhepatic catheters, which aid in identifying the ducts during surgery. While looking at the anatomy, it's important to realize whether we will require or not require a hepatic resection. We will spend a few minutes later in the talk talking about hepatic resections in benign biliary strictures. And most importantly, we need to identify whether the case is a complex stricture or not, whether the patient has an atrophy, hypertrophy complex. An MR is a very good investigation that will give us the answer to this, help in visualization of both lobes of the liver. Moreover, even if we have just a cholangiogram or a PTC, crowding of ducts and the biliary radicals on one side will give us the information whether there is some amount of atrophy, hypertrophy complex or not. Planning a surgery for recurrent strictures or for high strictures, again, we have a word for that in the upcoming slides, or in patients with portal hypertension, this requires commitment by the surgeon to plan the surgery well, which will actually lead to the best possible results. So this is the patient. He is a 37-year-old male patient who had come to us following 3 weeks of a lap converted to open cholecystectomy. He came to us with a total bilirubin of 39, swinging fever, and we got a percutaneous drain placed in segment 6. This is about 6 weeks following his drainage procedure, and now we are going to plan the surgery for him. What most people would say that a right subcostal incision is probably the best incision that is possible. One may want to take the incision along the open cholecystectomy scar, but I need not explain here that the open cholecystectomy scar here is way above and on the subcostal margin, and therefore we went a little lower down. It also makes sense to palpate the liver before opening the abdomen, because the incision should be placed about 2 or 3 centimeters below the lower margin of liver, which is palpated. The right extent of the incision is probably the most important one, so that one is able to put their left hand inside while doing adhesiolysis. The left extent may not be that important. In some oddly thin patients, a midline incision in simple strictures might just do the job. in patients with atrophy-hypertrophy complex, most often, since the right lobe of the liver is atrophic, the common bile duct, which is actually anterior, goes posteriorly. So in order to access that, a thoracoabdominal incision might be required. It's important that the liver is completely mobile while doing the surgery. The falciform ligament should be divided to the base so that when the assistant holds the retractor to identify the bile duct at the hilum, the liver gets the maximum dig back force or the lever so that the hilum can be exposed for the surgeon. This is a very common scenario which is encountered following a surgery for biliary stricture following a lap cholecystectomy. A good number of these patients have a biloma in the immediate period following a cholecystectomy. They might have had an external biliary fistula which either closed off to form a stricture. In these cases, it's important to realize that there is often an internal fistulization between the common bile duct and the duodenum. So while doing the adhesiolysis, while we make sure that the inferior surface of the liver has been made free from these adhesions, the hepatic flexure should be taken down completely and a cauterization should be performed so that the porta can be accessed posteriorly and the duodenum can be identified safely and brought down rather than inducing a duodenal injury. This is what every surgeon wants to see. The base of the quadrate lobe where paradise is found during surgery for benign biliary strictures. So the assistant digs back with the retractor so as to expose the base of the quadrate lobe. The line of the umbilical fissure, which can be identified simply by holding the round ligament or the ligament teres up, leads to the hilum from left to right. So if we look at the schematic representation of what this is the most important anatomical identification that is required for surgery in benign biliary strictures. At the hilum, this orange tissue is the thickened part of the Glisson's capsule or the hilar plate, which needs to be incised to reach the hilum or the junction of the left hepatic duct and the right hepatic duct. In about 85 to 90% times, the right hepatic artery traverses behind the hilum and all vascular structures are lying posterior to this. So incising the ductal structures at this point can lead to a straight identification of the biliary system because no vascular structures are usually encountered anterior to this. This may not be true in patients with atrophy-hypertrophy complex. Since the right lobe is atrophic, the porta turns in a counterclockwise fashion, taking the portal vein of the left side and the arterial system anteriorly. Sometimes a parenchymal bridge is encountered between segment 3 and segment 4, and once that is divided, it becomes easier to rotate the quadrate lobe so as to expose the hilum. Once the hilum has been exposed, what we call the Hep-Quanodes technique has been performed, or we are ready to identify the bile duct. It's important that we place a needle first in the structure, make sure we are not pricking a portal vein or an artery, and bile is aspirated from the area before we move forward with an incision. Once we confirm the location of the bile duct, a small stab knife incision is given to perform a ductotomy. We can either we incise the hilar plate, identify the duct, and open the duct. Usually a gush of bile is found, and it makes absolute sense to collect a sample for culture so that if at all patients develop cholangitis in the postoperative setting, we know what needs to be given to them at that point. At this point, a right axial forceps is inserted into the ductotomy to see the direction of the left ductal system and the right ductal system and plan the stoma. Stay sutures are placed at this point of time. The anatomy is made sure of that we are dealing with the hilum or we are dealing with the left ductal system so that we can start incising in the directions that will give us the maximum width of the stoma. So ideally, we want a stoma size of 2.5 to 3 centimeters at the hilum, extending into the left duct and opening the right ductal system. It's important to realize that the hilum is actually made of 3 ductal systems and not just 2. We must identify the opening of the right anterior and the right posterior sectoral ducts while doing a proper anastomosis. Once that has been done, the anterior stay sutures are placed. And by this time, of course, we have made the rule limb of jejunum and transposed it in the supracolic compartment and are ready to perform our duct to mucosa side-to-side hepaticojejunostomy. So like I said, the anterior stay sutures have been taken. We have taken the angles and we have railroaded the sutures, and the jejunum and enterotomy has been performed. First, the posterior layer of the sutures are placed using an delayed absorbable suture. What we usually prefer is a 4-0 or a 5-0 PDS suture, which gives excellent healing results. The posterior knots are placed inside while the anterior come outside. So this is what the picture looks like, that there is a posterior layer of sutures. Once these will be cut, the anterior stay sutures will be used to close the anterior layer of the jejunostomy. What we can see in this stoma over here is the catheter of segment 6 duct that was placed percutaneously to alleviate the cholangitis the patient had come to us with. For this patient, we did not remove this. We left it in situ, and we removed it in the postoperative setting on the third postoperative day, and the abdominal drain was removed 2 days after removing the PTBT catheter. So planning surgery for an E1 or an E2 or even a good E3 is rather easy when we are talking about surgical planning. The surgery in itself, of course, may not be very difficult, but in some bad E3 and type 4 bismuth strictures, we might want to do something more than just a hepaticojejunostomy. In some E3 strictures, the floor of the confluence may be scarred, and it may not be able to get one may not be able to get good drainage of the right ductal system. In type 4 bismuth strictures, the right and the left ducts are separated, and the unhealthy fibrotic tissue at the hilum, which is ischemic, can actually result in high failure rates. So in these patients, it is debated that is there a role of performing an upfront hepatic resection on the right side versus a secondary procedure? Secondary procedure being that a hepaticojejunostomy is performed upfront, and if the procedure fails, we go back and do a right hepatectomy. That's a very, very difficult undertaking. A surgery for benign biliary stricture in itself is a tenuous and a difficult task. Doing a reoperative surgery on a patient who has failed a stricture surgery and then going ahead and doing a hepatectomy has a very high postoperative morbidity and a prolonged length of hospital stay. So when we're talking about hepatectomy for benign biliary strictures, like we discussed just a minute ago, for complex injuries, that is the bad E3 types and type 4 bismuth classification, there might be a role of doing a right hepatectomy, which exposes the healthy bile duct of the left ductal system, and a good anastomosis can be done, which results in more durable and long-term repairs. In patients who have an atrophic right lobe with cholangular abscesses, they mandate a resection of the right lobe of the liver. And in some isolated cases, some surgeons would say that where there is an isolated sectoral duct injury leading to a leak, in which it's almost impossible to establish biliary enteric continuity, probably the best answer would be to do a resection of that particular sector and let the rest of the liver be as it is. This is my last slide, and I cannot emphasize on this enough that the determinants of a successful repair are threefold. The stricture itself, the stricture decides how good or bad is going to be. Primarily, we need to know the level of injury. There is some data to say that patients who develop an external biliary fistula have worse results than patients presenting only with a biliary stricture. If the patient has undergone a repair previously, the chances of a redo repair and the success of a redo repair are rather low. So previously, Professor Romero emphasized that the first repair should be the best repair, and that tenet holds. It's held its strength for the last 4 decades in HPB surgery now. There is some evidence to say that an associated vascular injury in the form of a right hepatic injury has an implication on the long-term success of hepaticojejunostomy for bile duct injury stricture repairs, but the data of this is soft on either sides. Patients who have complex strictures, recurrent strictures, those with atrophic, hypertrophic complex, or portal hypertension tend to have a higher failure rate than those who undergo surgery for a type E1, 2, or 3 biliary stricture following a bile duct injury. The surgeon who undertakes this procedure should be true to his capability, needs to be a biliary surgeon. Now, one can argue on what defines as a biliary surgeon. Anybody who is doing hepaticojejunostomy, biliary work, pancreatoduodenectomy, and liver surgeries on a regular basis qualifies to do a surgery with this much of expertise is required. Some important tenets of the surgical technique, I have said these in my talk before, but I cannot emphasize them enough. We need to achieve complete drainage of all ductal systems. The isolated ducts should be identified and addressed. Patients in whom the stricture is higher up, complex injuries, those with a leak from an aberrant ductal system, they benefit from a percutaneous transhepatic catheter placement. It helps in identifying the ducts during surgery, and those can be left as a transanastomotic stents in the postoperative setting. Hepatic resections in cases of complex strictures, type 4 strictures, they may have a better role than doing an upfront hepaticojejunostomy. Though a lot of centers like Johns Hopkins routinely leave transanastomotic stents following any biliary stricture repair, we don't believe in doing routine stenting except in cases which are rather difficult. It's important to achieve a wide stoma, drain all ductal systems, and achieve a tension-free side-to-side ductomucosa hepaticojejunostomy. Thank you, and I'm happy to take any questions that are.
Thank you, Dr. Kapoor. A very informative talk and a very excellent surgery. We look at the picture very excited. Yes. And I think we should open discussion for a straight talk, right? And I give maybe for me to have this discussion. Anyone have this question?
Okay, I think we can start the panel discussion first, and then as we go along the way, we can answer the questions in the chat box. So let's start the case discussions, if you will, Dr. Maduma.
Hello. Good evening. Hello, can you see my slides?
Yes.
Okay. We will be discussing two relatively more simple and common cases pertaining to biliary strictures. Okay, for the first case, we have a 56-year-old male with a chief complaint of jaundice. He underwent laparoscopic cholecystectomy 2 years ago with unremarkable post-operative course, and he came in with less than a week history of icteric jaundice. Here are the laboratories with elevated bilirubins, alkaline phosphatase, Patient seems to have normal liver function, and patient is not in cholangitis in physical examination. Ultrasound was done, showed intrahepatic, dilated intrahepatic bile ducts with echogenic foci and acoustic shadowing mid CBD. Okay. What would be our suggested next step for our case? Dr. Would you like, I will just sequentially for our panelists. I'll call you by alphabetically, or
I think we should go ahead and do an MRCP and see and look at the anatomy of the extrahepatic biliary system, and make sure that we have traced the anatomy up to the second order biliary radicals.
Okay. So for this case, do you have any other more comments?
Yeah.
For this
me,
case,
hello. Yeah. For me, I will order for a CT scan and check for the vascular anatomy of this patient.
Okay. So what are we? So we're thinking of an biliary stricture, no? Probably from the previous surgery. For the patient was underwent first ERCP, was referred to an endoscopist, and because of the stone, the stones were about 1.2 cm, and there was failure in stone extraction, and there was suspicious mid to distal stricture in the CBD. Okay. To Dr. Cañones, what would you think would be the next step, or do we have other ways for endoscopic management on this patient?
If the ERCP was done before the imaging, definitely I will not do the extraction, because I'm not sure with the reason why there was a mid to distal CBD stricture. If I have the endoscopic ultrasound available around, I would do the endoscopic ultrasound immediately to assess if there is a mass at the pancreatic head, or probably a lymph nodes compressing the mid to distal CBD. And then after the procedure, we'll request for the imaging, either the CT scan or the MRI. But definitely I will not try to remove the stones, because it will be very hard to extract these stones, especially if your opening is not as big, even if you can crush this or fragment this to small pieces. So what we usually do is just put a stent, just like what the endoscopist did in this ERCP.
Thank you, doctor. Do we have more inputs? Yes.
I just want to say at this point that a patient who is presenting with obstructive jaundice 2 years after a laparoscopic cholecystectomy and the ultrasound is showing a mid-CBD stricture, it might be prudent to get an imaging done before doing an invasive evaluation. If we are thinking in terms of a post-cholecystectomy bile duct injury leading to a benign biliary stricture, although it has a huge medical legal implication to document whether there is an associated vascular injury or not, it probably will not change the surgical plan. So we can bend on the side of getting an MR abdomen with an angio with an MRCP that covers almost everything. It gives us the delineation of the biliary anatomy. It will tell us the status of the liver. It will tell us whether we are dealing with a malignancy or not. And the angio will give us information on the vascular structures. Depending on what the picture looks like, we can decide on the next step, which is an invasive procedure like an ERC or not.
Thank you, Dr. Diksha. So usually in poor resources settings, no, the most common differential of the endoscopist or the doctor would be a primary stone. So maybe that's the reason why they proceeded with ERCP right away. They did not consider stricture yet. Now the patient underwent MRCP, which showed stones in the mid CBT and stricture in the distal third. There seems to be no masses or vascular in an MRI, vascular injury on MRI, a gross vascular injury on MRI. For our panelists, what would you think? What would you think would be our next step or plan for these patients, be it endoscopically or surgical?
I think this shows a stricture in the lower end of the CBD. Do we have just an MRCP or we have other images of the MR?
We do not have. Dr. Mendoza, do you have an MRI or just a plain MRCP?
I think for this case, the MRCP was just is the one shown here only. No MRI imaging.
Right. So if there is no clinical or radiological suspicion of malignancy, then the next step is surgical, but then it's also important to document. So one might err on the side of getting an EOS, taking a tissue sample and documenting that we are not dealing with a malignancy.
Yeah, totally. I agree also. So with this case, the importance of getting a CT or other axial view or is also to see if there's an atrophy or hypertrophy. If in case few years ago there's a vascular injury of this patient, you will see an atrophy or hypertrophy. But looking at this MRCP, I don't see any atrophy, because if you can see the spread out of the biliary ducts, there's no portion that you see there's no evidence of any atrophy, but by just looking at this MRCP. But it's better if you could present to us the axial view of this imaging. So that's very important also, because it will definitely change your reconstruction, not just by doing Roux-en-Y or bypass, but you might also think of a possible with a possible hepatectomy on this case. On a case, but in this case, I don't think hepatectomy is needed for this. The next is you have to look at your patients, of course. What's the patient status? It should be free of any sepsis. Okay, so I think it's not in cholangitis, right?
Yes. Thank you, Dr. Diksha and Dr. Romero. So as what was mentioned earlier, the first surgery is always the best surgery. So we must have adequate planning, especially with the images. Was there concomitant vascular injury? Is there presence of strictures, which may be a neoplasm, or is there a tumor which may cause a stricture? Dr. Cañones, do we still have any endoscopic plans for this patient, suggested endoscopic plans?
As I said earlier, sir, for mid to distal strictures, I would, especially for elderly, as what is also the concern of one of our members in the chat box. I would be leaning towards a pancreatic head mass or a mass that is compressing into the or onto the mid to distal CBD versus biliary injury, because I think a biliary injury would be more proximal. But if you can see in this MRCP, especially in the cholangiogram during the ERCP, there was attenuation of your mid to distal CBD. So I think it's really important to document the presence of tumor, and if there's presence of tumor, if this is resectable or not resectable, because of course, as surgical endoscopist and a surgeon as well, I would be also planning for future resection. If this is indeed unresectable, then probably I can insert a metallic stent for this patient after doing biopsy using the EUS, or if there's endoluminal invasion, or if it looks resectable, then I could just probably put the stent in just to tide over the cholangitis if there's cholangitis, or just to have liver rest, because probably this patient would be jaundiced for a while. But definitely I will not prioritize the removal of the stone. Drainage is very important at this point.
Okay. So the case, it was assessed to be a benign biliary stricture, and the patient was planned to undergo a biliary enteric bypass. So intraoperatively, the patient was found to have a stricture in the supraduodenal portion of the CBD. There were also stones which were extracted. 2 stones are 1.2 cm. The largest was 1.2 cm. Patient was discharged on the 5th day post-op. But then patient came in. Patient was unremarkable until 1 year later. The patient had episodes of epigastric pain, low-grade fever, and symptoms of biliary obstruction. So here we are, because of the previous surgery, we are thinking of another anatomical obstruction. So for this case, as mentioned by our panelists, we have to do cross-sectional imaging with contrast studies. Do you have anything to add more for this case to our panelists?
If the patient has come back with the features of obstructive jaundice along with the routine blood investigations, actually at 1 year, I would like to repeat an MR abdomen with IV contrast and get an MRCP done. That delineates everything again. So we understand what is the cause of the jaundice. Are we missing a tumor in this case? Because at 1 year, if a hepaticojejunostomy has failed for a type 1 stricture, we need to be very sure we're not actually missing on a tumor.
Okay, so again, an MRCP was done and showed recurrence of primary stones over the anastomotics. Should consider hepaticojejunostomy junction. This is the last slide for the case. If you'd like to add more concepts in which we could discuss on the future management of this case, you're free to do so. Or if you have questions from other audience.
Yeah, I have a question in this case. Did you do a hepaticojejunostomy, right? Is this side to side? Because it seems that I can still see the distal portion of the CBD.
This distal portion of the CBD might just be visualized. That's not the thing. That I'm not very convinced with the anatomy of the hilum that can be seen on this particular image. Ideally, I would like to sit with my radiologist, take a 360 turn on what the hilum looks like and what is the level of the stricture before deciding on the kind of intervention. Again, the two options remain that either we get an IR-guided procedure done, percutaneous transhepatic, catheter placed, followed by placement of a SEMS, because approaching this endoscopically is going to be difficult, or if at all there is a scope of doing a reoperative surgery. Now, selling a reoperative surgery to a patient who is 1 year down the same surgery is kind of difficult. So probably dealing with the percutaneous transhepatic catheter placement and a SEMS placement might be the best next step for this patient. provided everything's been discussed with him or her.
Okay.
Yeah, I agree also that in this case you have to roll other causes of strictures. So that's why in our practice, if we do bypass surgery, more so benign biliary strictures, we put a Hudson's loop so that for the future access of the endoscopic surgeons. So if this is just an anastomotic stricture, we can do something and we can access that loop, then put a stent, or if there's no access, yeah, it's right for Professor Kapoor to do a percutaneous procedures and try to put a stent on that if this is just an anastomotic stricture. So that's it.
Okay. Dr. Romero, do you also perform dilatation through either through the percutaneous approach or through the Hudson loop?
I have no experience on
for example, if it's a benign stricture.
I have no experience on doing percutaneous dilatations, but no, I'm not the one who does that, but the endoscopic surgeons in our institutions who try to access the anastomosis through the Hudson's loop.
Okay, so Dr. Arlene, what are your?
But of course, in this case, you have to be very sure what caused the stricture. You should have a diagnosis first. So if this is really just an anastomotic stricture, so you have to plan, and we have to hear something from the endoscopic surgeons if they can still dilate, or the radiologic interventional radiologists if they can do dilatation. Well, it's okay. But if they said that no, we cannot do dilatation anymore, it's too tight, and that's the time the hepatobiliary surgeons will go in and manage this case.
Okay. For theoretical purposes, for example, if it's just a benign stricture without any identifiable malignancy, how do you usually dilate through endoscopic means? Dr. mentioned a while ago, put stents transanastomotically.
Technically, sir, I think in the Philippines, Rizal Medical Center is or we have the highest number of the hepaticojejunostomy with the Hudson's loop because of the surgical endoscopy team that can always come in case of these occurrences. But for other instances wherein the hepaticojejunostomy is too long, especially if it's the loop or the side to side or the end to side, there is a scope called the double balloon or double balloon enteroscope. It's a long scope that is or that can be inserted through the limbs and can do ERCP, or it can access the hepaticojejunostomy anastomosis. And from there, you can do your balloon dilatation or can put multiple stents. So to obviate the use of a long scope, which is not available in most of our institutions here in the Philippines, we did the Hudson's loop. So our unit decided to put Hudson's loop. So it's from the skin, we locate the jejunal end. So the axis is shorter as compared to your hepatico-J. So I think we've only done of all the cases we've done 2 or 3 dilatation from the stricture from the hepaticojejunostomy through the Hudson's loop. And also one of the advantage of this is that you can see if there are tumor overgrowth or tumor recurrence, if in case this is or malignant. or you can have a direct visualization of what's happening in your anastomosis.
Okay, thank you for that, Dr. Fernandez. We will try to answer related questions regarding hepatico surgical strictures. First question, for smaller than 1 cm hepatico jejunostomy, will stents help for this?
Is that for me?
For our Dr. Diksha or Dr. Raymond? Are you, maybe Dr. Kakukum is referring to surgical transanastomotic stents, no? Without transanastomotic stents not inserted via ERCP or PTBD? Am I correct? For those cases, do you insert
So I'm just going to mention something here. For hepaticojejunostomy with ducts smaller than 1 centimeter, these are likely to be normal ducts. A duct with the biliary stricture is likely to be dilated, first of all. Either this stricture is really high up where there is ductal separation, or this question is pertaining to a ductal system which is not dilated. That means there is no stricture. In that case, there may be a role of putting transanastomotic stents. But if the surgeon is confident that a good anastomosis has been done, a hepaticojejunostomy for a biliary stricture with a wide stoma and all segments have been drained and the ductal tissue is healthy, there is probably no role of putting routine stents. Although some groups, like I mentioned, John Hopkins, does put stents across all anastomotic stricture, anastomosis. But this question clearly, I mean, a 1 centimeter duct is not dilated, and therefore it's not for a biliary stricture. So if it's a normal duct, I will probably, and if it's a tenuous anastomosis, I will probably put a stent.
Thank you, Dr. Diksha. And when do you usually remove your transanastomosis? Okay, so.
Sorry?
I think Dr. Raymond, go ahead.
Finish first. Hello, Dr. Madumba. Yeah.
Yes, sir.
I would like to answer the question also. We don't usually put routine stent even in less than 1 centimeter, but might probably for ducts that is less than 6 centimeter, 6 mm. We might put a stent on it. But there are ways how to dilate the ducts, like what Professor Kaffer did in her video. They did a hepkinode. They dilated the duct to the left, the ducts to the left hepatic duct. So there are ways to make it bigger. Okay, and one thing is very sure to make your anastomosis patent. It should be well vascularized. You should have what I'm saying a while ago. There should be no vasculobiliary injury. There's no vascular injury concomitantly on your anastomosis, so that you will have a good bypass. Okay, and also regarding the stent, if you put it, there are study. I think there is study or proposed study on bypass surgery like this, for surgical bypass, and if you put a stent, it should be removed in less than 3 months, because if it's more than 3 months, it's already they put the grading. I think the group of Professor Stasberg did this proposed standards of grading of bypass surgeries. Grade A, if you have a patent bypass without stent, or if there's a stent in less than 3 months, you have removed it, then it's a grade A. But if not, there's a higher chance that there will be a stricture soon. So that's how they grade it. I think it's one of the journals made by the group of Professor Stasberg. So be sure you will remove the stent in less than 3 months, and your patient should have no repeated jaundice, no cholangitis after that. And I think it's about 1 year for the endoscopic management of bile duct injuries.
Okay. Thank you very much, Dr. Romero. No? So very important to look for the vasculature, and I think the question was is very applicable now for injuries. No, are you for early injuries now which you identified during the operation, in which the in which the hepatobiliary surgeon attempt to do a repair because it is found in drop and the ducts are not yet dilated. Okay. Okay. Okay, another question. Do you think Hepkino procedures could only be done by experienced trained surgeons and must not be attempted by non-HPB surgeons?
Yes, I think that is absolutely correct statement. This is a quality of life measure, and this is a surgery which is being done for benign disease. In a surgery which has already caused a complication, a low acuity operation like lap cholecystectomy, if it's caused a complication, it's best in the interest of the surgeon who is trying to do the operation and the patient that the case gets referred to somebody who does this on a regular basis.
Okay, thank you, Dr. Diksha. Any comments, Dr. Romero, Dr. Okay, so
yeah. So what I've said a while ago, you have to evaluate yourself. If you're the one who does a lot of this and you have low morbidity, you may do so. But again, in dealing with this bile duct injury, it's not simple. It's very complex. So what we suggest is, of course, an MDT approach or multi-specialty should be involved in this procedure. As what I've said, the first repair should last, okay? Because redo surgery, it doesn't really give longer durability. Okay.
Thank you, Doctor. For next question, early versus delayed repair for bile duct
Excuse me,
injury.
Dr. Maduma. Maybe we can answer one more question. We're a little pressed for time. So one last question. Thank you.
Okay. So, okay, this is our next question. So, early versus delayed repair of bile duct injury. What is your opinion? First, we could define what's early versus delayed, the timeline. How do you think, Dr. Diksha?
Yes, thank you for the question. That's a very, very important question. I've been reading the chat box, and I'm going to combine this question which was asked the last, as to please decide on the timing of repair for a bile duct injury. So let's first understand that a bile duct injury can have two kinds of presentation. Either the patient can have a leak or the patient can present with jaundice. In the early setting, if the patient is coming with a leak, we need to make sure that there are no undrained collections. And if it's a cystic stump leak or a side leak, in such patients, doing an ERC, a papillotomy, and a stent can actually result in resolution of that leak and can take care of the bile duct injury at that point. The controversy or the discussion on early versus delayed repair comes in patients who have an external biliary fistula. These are patients who have some amount of connection from the bile duct to the external part of the to the outside of the abdominal wall, and there is some amount of bile which is draining. In that case, before one goes in for a repair, it makes sense to wait at least for 6 weeks to 3 months. Make sure that all sorts of infections, abdominal collections, this has been taken care of. The patient is fit to undergo a surgery, and then plan a repair. A particular timeline, be it 6 weeks or 3 months or 6 months, that timeline does not hold true. I think it's the checklist needs to be there as to what we need to achieve before considering a surgery for a patient. The system should be properly delineated. There should be no sepsis. Any intra-abdominal collections should be drained. And if it's a fistula, it should be an controlled fistula. Now, patients with an early injury who are simply clipping of the bile duct, they can be operated the very next day. These are patients who have a sterile obstructed system. No intervention has been done. There is a clip on the common bile duct. The surgeon has realized it, referred the patient to an HPB surgeon who needs to do the hepaticojejunostomy. In these patients, the surgery can be done the very next day. For everything else, I think these tenets are important.
Thank you very much, Dr. Diksha, for that comprehensive explanation. I think we don't have any more time for. I think we have learned much from this discussion. I'll pass the floor to Dr. Mendoza.
Thank you, Dr. Madumba. We apologize that we couldn't answer all the questions in the chat box, but we had a very fruitful and lengthy discussion on the topic. And so we will cut it short at this point. And we would like to thank the panelists for all your expert opinions and discussion. And so before we end tonight's symposium, let me turn you over to our TUGSS coordinator, Dr. Vermi Garcia, for some words.
Hello. Good evening once again. Thank you for joining us today in our lecture on and series on benign biliary stricture. I hope that we have learned a lot from this discussion. And I thank our speakers, Dr. Diksha Kapoor, Dr. R.J. Romero, Dr. Arlene Canones for such a very comprehensive lectures about this topic that we have tonight. And also Dr. Madumba for a very good case presentation. Please allow me to share my screen. Okay. To present the certificate of appreciation, Dr. Mendoza. Here to present a certificate of appreciation. Here to present a certificate of appreciation from TUGSS Asia to our speakers for tonight, who has shared their invaluable expertise to us as a faculty member. This regarding benign biliary stricture in the venue of Zoom meeting today, Saturday, 29th of October, 2022. So again, thank you for attending, and to our speakers, thank you very much. Good night. Dr. Armin?
Yeah, thank you very much, Dr. Garcia. And again, thank you to our speakers for tonight, Dr. Cañones, Dr. Romero, and Dr. Kapoor. Thank you everyone for your attendance.
Thank you very much. It was a pleasure to be on the forum.
Thank you very much.
Thank you.
Thank you.